Watch that language, Pippin. Yeah, I'm only joking. Let's start that one. Bear with me. Okay, Christine, I think the floor is yours. Yeah.
Okay, just bear with me a moment while I get this set up. No, why isn't it happening? I had this earlier. Where's it gone?
Go into open.
Yeah.
The file.
Oh, through it up there.
Yeah, that's it. You should have it there, that's it.
Let's go from that one then. Being model. Oh, here it is. Sorry about that.
Okay, I'm going to mute myself, so I'll hand the floor over to you now, okay? Sorry.
Okay, thank you very much, Dipen. Thanks for your kind introduction. Well, good evening, everyone. I hope you can all hear me clearly. Like many people, I've had a dreadful cold recently, so please forgive any coughs and sniffles during this talk. As Dipen said, this session has been sponsored by Almiral UK, so thanks very much to Almiral for making this possible. During the next 45 minutes or so, I want to talk to you about dry skin and how you can help people with dry skin. And I hope that in the course of this, I can infect you with some of the enthusiasm that I feel for dealing with patients with dermatological disease. This is a big topic, and I can only cover the highlights today, but I'll be focusing on the things that I think will be interesting and useful to you. So, the purpose of this evening's presentation is to educate you about dry skin and effective emollient use. I'll be emphasizing effectiveness quite a bit as we go through. I help you identify situations in which patients would benefit from additional advice, and I want to give you some tools that will equip you to play your part in the multidisciplinary team that cares for patients with dermatological disease. I also want to introduce the idea of some situations where prescription intervention medicines use reviews could be undertaken. We'll cover this in much more detail in the workshop in the autumn, but I want to introduce some of the points that I think are important here. So, why does dry skin matter? Well, I guess you know the answers to this, but let me give you my list. Dry skin is common. In surveys, 50% of people claim to have sensitive skin, that's skin that's easily irritated or dried. Dry skin is also a feature of many diseases, notably eczema, psoriasis, ichthyosis, and it's a feature of systemic diseases such as diabetes. It affects all age groups, and it affects both men and women. Most importantly, it causes discomfort, distress and embarrassment, and impaired function, as we will see. And another important point, of course, is we know a great many people self-treat and will turn to the pharmacy for advice. So, good reasons to take an interest in dry skin. It's not a trivial matter. I would argue it's an important role for community pharmacy because the community pharmacist is in a position to educate people about what causes dry skin and how to prevent it. Also, the community pharmacist is able to explain the role of emollient treatments and advise on the choice of emollients. And I'm going to spend a bit of time on that and then talk about how to use emollients effectively. Finally, you're also able to explain how emollients work alongside other prescribed topical treatments for those patients who have prescribed topical treatments. It's interesting that many people are unaware of how to choose and use emollients effectively, and they are amazed at the difference the right product and correct use can make. And that's really very rewarding for pharmacy staff. Another comment on what's in it for pharmacy. I would argue there are plenty of avenues for medicines use reviews here, and I'll point some of those out today. There is the opportunity for increased sales of emollients, the opportunity to build customer loyalty, lots of opportunity for professional satisfaction, and opportunities to build relationships with the primary healthcare team. So lots of good reasons for being good at dry skin and indeed skin in general. Now, here's a reminder of the anatomy of the epidermis. You'll remember that there are two layers of skin, the dermis, the bit with the blood vessels and sweat glands and so forth in it, and the surface layer, the epidermis. When I was a student, I was told this was just kind of dead stuff sitting there waiting to fall off. But in fact, we now know a lot of important things happen in the epidermis. Most notably, the epidermis is where we find the skin barrier. Now, let me just take you through the diagram and then I'll come back to the skin barrier. The bottom layer, this is the layer right next to the dermis, is the basal layer, or stratum basale, down here, and these are actively dividing cells. So this is where the new skin cells are made. They then migrate upwards, up all the way up to the surface, over the next 14 days or so, and spend another 14 days up here before they're gradually shed from the surface. The bottom layer is the basal layer, as you would expect. This next layer is called the spiny layer, or stratum spinosum. It doesn't look spiny on this diagram, but under the microscope there are little projections, which makes it look spiny. The green layer here is the stratum granulosum, the granular layer. Although it doesn't look like it on here, under the microscope it's full of speckles, which is how it got its name. The stratum lucidum only exists in a couple of places, as it says over here, in the palms and the soles. So most of the skin just has 4 layers in the epidermis. We've been through the first 3. Then the top layer is the stratum corneum, or the horny layer. What you'll notice about these uppermost layers is that there are no nuclei in the cells. They're flattened and relatively dry. However, it isn't just a layer of dead stuff waiting to fall off. These cells, we know, are knitted together. They're linked together by corneodesmosomes, little protein bridges that hold the cells together. The cells are also tightly packed one against another, and they're packed because they're well hydrated. More about this on the next slide in just a moment. And they're also covered in a layer of lipid. If I go on to the next slide, we've got all this in words. Tightly packed corneocytes. They're called corneocytes when you get to the top. They're called keratinocytes when they're lower down. But basically, tightly packed skin cells, tied together by corneodesmosomes, coated in lipid. You can think of them a bit like bricks and mortar, if you like, where the cells are the bricks and the lipid in between is like the mortar. And together, that holds the skin together. As I said, the cells are tightly packed because they're well hydrated, and that's because they're full of natural moisturizing factor, which is a natural humectant. It pulls water in and keeps those cells nicely swollen and pressed against each other. The effect of all of this is to form a very substantial barrier that we call the epidermal barrier, or the skin barrier. And the skin barrier does 2 very important things. It reduces or limits the amount of water that is lost from the skin. I'm not talking about sweat here, I'm talking about just the water that moves through the skin just in the way that it would do through any other substance. And the barrier also prevents the entry of allergens, irritants, microorganisms and so forth. So it's doing all this, and while it does it, remember, it's strong, it's pliable, it's flexible, and it's really quite attractive. It's remarkable stuff, this skin. Now, when things start to go wrong with the barrier, that's when we have problems. And this diagram is to indicate the factors that are involved in the development of dry skin, or eczema. Incidentally, eczema and dermatitis are interchangeable terms. Effectively, they mean the same thing. Let's just, and eczema is often described as a gene-environment interaction. Let me explain why. If you accept that this pink box in the middle represents skin with an impaired barrier. So, in the first place, there may be genetic factors that mean your skin is more sensitive, or let's say this skin is more sensitive or less robust than other skin. Of course, patients don't come in saying, I've got a genetic malfunction in my skin, but what they notice is that their skin dries out more quickly than other people's, or appears to be more sensitive to being wet or being exposed to chemicals or other drying agents. Once the barrier is impaired, if it's exposed to other environmental factors that can further damage the skin, and these are very ordinary things, frequency of washing, for example, use of soaps and detergents, exposure to solvents. As you know, soap and detergents and solvents will remove fat. They remove skin lipids. Frequent washing removes skin lipids. Once the barrier is weakened, water loss increases. So there is greater transepidermal water loss. Once the skin starts to lose water, some of those cells shrink a little bit, and they're no longer pressed together so tightly. The barrier is weakened. Obviously, if you wash some of the lipids out, the barrier is weakened. It's like chipping the mortar out of a wall, if you think of it. And once these things start to take effect, it's possible for irritants and allergens to penetrate. And if you like, a downward spiral is started. So I mentioned that water is terrifically important in the skin. In fact, the stratum corneum, that top layer of your skin, contains up to 20% of water. The stratum corneum receives its water from the dermis. It's soaked up, if you like, from the dermis. It doesn't come from the external environment. Transepidermal water loss across the skin, increases when the skin barrier is damaged. We know from experiments this happens in eczema. We know you can make it happen by removing skin lipids through the use of a lot of soap or solvents. When the water content of the stratum corneum falls below 10%, there is clinical xerosis. Xerosis is just the word for dry skin. But that's the time that you start to notice little flakes of skin coming off and skin feeling rough. Now, successful treatment of dry skin, I would like to say, is not rocket science. It depends on correct treatment of the underlying condition. For example, if the condition is eczema or psoriasis, proper treatment will help. Effective use of emollients is always part of the treatment. But this bit is often overlooked, and it can lead to treatment failure. Now, treatment failure with emollients occurs because patients don't use enough, don't use them frequently enough, don't use a suitable emollient, and we'll talk more about this, or because they undo the benefits of the emollients by using inappropriate wash products that take them all out again, or they don't get the expected improvements because of incorrect use, and then they stop using them regularly, and the downward spiral starts again. Incidentally, where a patient is having prescribed treatment, any of these could be triggers for a prescription intervention medicines use review. I'd just like to remind you about the signs and symptoms of dry skin. I'm sure you know what they are, but it's sometimes useful if you're talking to a patient to know what to ask for, what to ask about. Tightness of the skin, especially after showering, bathing, swimming, that sort of thing. And I don't just mean tightness, feeling a little tight on your face when you've washed it. Patients with really dry skin sometimes find their skin tightens so much that it's difficult for them, say, to flex their fingers or to bend their ankles. Skin can tighten up that much. Loss of plumpness and shrunken, dehydrated appearance to skin is also a feature. Dry skin generally looks and feels rough, and this is uncomfortable. It catches in fabrics, and it doesn't feel nice. There's often flaking or scaling as well, and itching. And this is always bad, because itching, as you know, always leads to scratching. And that's nice for a short time until it starts to itch some more, and then people scratch some more, and substantial damage can be done to skin, especially in conditions like eczema. But even just a bit of dry skin can get quite itchy. There are sometimes fine lines or cracks. There's often redness if there's inflammation due to eczema or scratching. And there can be fissuring, deep cracks. And deep cracks on the hands, for example, can be a real problem because when you flex your fingers, they open and bleed. And that's uncomfortable and actually quite embarrassing for people in public situations or at work. It also makes everyday living very complicated and uncomfortable. It's difficult to cook, wash, clean, care for children, service the car, do the gardening and so forth, if every time you flex your fingers it cracks and bleeds. So, dry skin conditions. Well, I've already mentioned eczema, psoriasis. We could add ichthyosis to that. And sensitive skin, don't dismiss it. As I said, actually quite a lot of people suffer from sensitive skin, and we're beginning to understand more about the genetic defects that might mean that it really is true. Of course, dry skin also occurs in systemic diseases such as diabetes, hypothyroidism, renal failure, AIDS, and in fact many others. And of course some drug treatments will also cause dry skin. But most of the time we're going to be dealing with these up here. So just a word or two about eczema. I just put up here the common forms of eczema. So as you know, there's atopic eczema, the one that has no obvious cause, but the one that's linked with asthma, hay fever, allergic rhinitis, and so forth. More about this on the next slide. Another couple are really important. There's contact eczema, and this can be contact allergic eczema due to contact with allergens, such as perfumes or preservatives, or contact irritant eczema, caused by, say, contact with detergents, the sort of thing you see in hairdressing assistants, or people whose hands are persistently wet for some reason because of their work. These two types of contact eczema. The nice thing about contact eczema is that, of course, often you can treat it by avoiding the cause. And I want to mention also gravitational eczema, and although it's not on here, another sort of eczema that occurs in elderly patients. We have a picture in a moment. Gravitational eczema is always associated with poor circulation in legs, and it's always in the elderly. So these are all fairly common. So worth knowing about. Just a few words about atopic eczema, because this really is astonishingly common. It's a chronic skin disease, it's relapsing, it's inflammatory, and it's jolly uncomfortable for sufferers. It affects up to 20% of children in this country, and many of them will grow out of it, but up to 10% of adults continue to suffer from eczema on and off for the rest of their lives. There is a genetic link. As I've mentioned, it commonly occurs along with asthma and hay fever, and it commonly starts in infancy. But here are the important things for us. It can be triggered or exacerbated by quite a lot of things, notably environmental irritants. And here they come again. Soaps, detergents, chemicals, household chemicals and things like that, even abrasive fabrics or extremes of temperature and humidity. It can also be triggered by exposure to environmental allergens, and here's the familiar list of environmental allergens: house dust mites, pollens, pet dander, and there may also be a role here for the Staph aureus superantigen. People with eczema always have skin colonized with Staph aureus. That's not to say they're infected, but they're carrying a bigger load of Staph aureus than others. And, of course, also endogenous factors. As you, I'm sure, all know, stress makes eczema worse. To remind you, here are a couple of pictures of eczema. This one shows the inside of elbows, and you can see it's difficult to tell exactly where the eczema begins and ends, but there's no doubt there's something wrong there. And it looks as if it's been scratched a bit, and it looks pretty uncomfortable, and we wouldn't want to go around with arms like that, and if you can help people to deal with that, that's really a good thing to do. You may have noticed on the previous slide that eczema has a predilection for skin creases. That's where the skin is thinner. So insides of elbows, back of knees, around the eyelids, around the neck, and so forth are very common areas in adults. Of course, in children, moving over to the picture on the right, in children the skin is thin everywhere, and it's not uncommon to see the face and head affected in this way, as shown in this picture. As I mentioned, dry skin is a condition that affects all age groups, and these two pictures show skin in elderly persons. This is asteatotic eczema, that's eczema occurring on elderly thin skin that only has a thin layer of fat underneath it. Sometimes called eczema craquelée because of the appearance. You can just kind of see it's like the appearance of cracked pottery a little bit. What you can see is that this skin is thin, sensitive. You just get the feeling that if you scratched it, it would probably break open and bleed, and I bet it itches as well. And the same goes for the skin on the picture on the right. That looks very dry and uncomfortable, and I bet that's itchy and pretty sore in some places. So that's just to focus you on the condition and remind you what it might look like. Oh, sensitive skin I've mentioned a couple of times. As I said, lots of people claim to have it. They will complain of burning, stinging or itching after using soap and some bubble baths and some cosmetics. Bubble bath is a real no-no if you've got dry skin. I'll come back to that later. People with sensitive skin may have had eczema in childhood, but they may not, and it may or may not be associated with diabetes and aging. But it's a real thing. If the patient says they've got sensitive skin, they probably have. Oh, I mentioned dry skin and systemic diseases, and I think I mentioned these earlier, diabetes, hypothyroidism as examples, but many others too. Now, let me move on to emollients. And this is a very important slide. All emollients do the same thing, but some emollients do it very much better than others, and some are almost no use at all. All emollients trap water in the stratum corneum. Remember how we talked about the skin barrier containing trans epidermal water loss, reducing the amount of water that's lost from the skin. A good emollient does that even more, and it does it by putting a film of lipid over the surface of the skin and reducing, as I say, water loss from the skin. Emollients will also mimic the barrier effects of the deficient lipids. If lipids have been removed from dry skin simply by washing or contact with detergents or solvents, an emollient will fill in the gaps, as it were. Now, the effect of doing that is that they restore or maintain the pliability of skin, and that's what we all expect from our skin. We expect it to be strong, flexible, and generally do the job. Interestingly, emollients also have a steroid-sparing effect. We'll talk much more about this in the workshop in the autumn, but it does mean that using emollients effectively means you need to use less in the way of topical steroid. As I say, we'll come back to that in the autumn. Now, there are problems with emollients. They wear off, they get washed off, people don't put enough on, or people don't apply them frequently enough. And I'm often asked what makes a good emollient. So here's my list. In the first place, it absolutely must have an adequate lipid content, because it follows, I think, from what I've said. The emollient is going to put a film over the surface of the skin. There's got to be enough lipid to do that. In my book, a good emollient also contains a humectant. Remember how we talked about there being natural humectants in the skin that pull in and hold water in the skin. I like emollients that have humectants in, because there is no doubt they are more effective. Emollients need to be unperfumed but have a pleasant smell. I say unperfumed because we know that contact allergens are often perfumes, or put it the other way around. Perfume ingredients are often contact allergens. But I would emphasize an emollient that you are going to use needs to smell pleasant to you, because you will be wearing it like a woman wears a cosmetic. So if it doesn't smell nice to you, you won't be tempted to wear it at all. And this is the reason why people need to test emollients out. There's nothing worse than going around for a day smothered in something that you can't stand the smell of. I would also say a good emollient needs to have good spreadability. Perhaps not a very scientific word, but actually it's the thing that is measured in emollient technology. You don't want to have to rub an emollient on. Rubbing often starts off itching. And itching provokes scratching, which provokes more itching, and you know how that goes on, the itch-scratch cycle. A good emollient also should not leave the skin feeling sticky. For many people, this is a real deal breaker. If you work in an office, you don't want to be the one who goes around leaving fingerprints on everything, and you certainly don't want to be the one who leaves greasy finger marks on documents. So, not leaving you feeling sticky. And of course, you don't want to feel horribly sticky under your clothes either. Finally, a good emollient is the one the patient will use, of course. There is nothing more expensive than the emollient that sits on the shelf. I've mentioned humectants once or twice, but let me just remind you what a humectant is. Typical humectants that are used in emollients are urea, which of course is in the skin as well, glycerin, propylene, glycol. There are a number of others too that are used, but these are very common. You can spot them just walking along the shelf. What they do when they're in an emollient is they attract water into the epidermis, and they attract it from the dermis. So the net result is that a humectant-containing emollient not only reduces water loss from the epidermis, like any emollient will do, by putting that layer over the surface, but in addition to that, they pull extra water into the epidermis. So, if you like, you get a kind of servo-assisted effect. They certainly increase the duration of emollient effects, and that's why I say I'm really keen on emollients that contain humectants. I'm an eczema sufferer, that's what I choose for myself. There are also additional ingredients in many emollients, and I just want to run through a few of them. Polydocanol is included in some. Polydocanol also goes by the name of lauromacrigold or Laur-S9. And it's included because it interestingly has antipruritic properties. Sometimes it's described as something with local anesthetic properties, which is very confusing because, of course, it's nothing like lidocaine or bupivacaine or those kind of things. The important thing is it has antipruritic properties, and that can be a real blessing. I'll come back to that when we're looking at emollients in a few minutes. One or two, not many at the moment, emollients contain ceramides. Now, ceramides are the major lipid component of skin lipids. So, in a way, this is getting to be a more natural emollient, if you like. More chance of mimicking the effects of deficient lipids. Some contain antiseptics. Several contain lanolin. Lanolin is an excellent emollient. It got a bad press years ago because the lanolin that was used many years ago was not well purified, and we believe that the causes of the allergic reactions that were reported were the impurities rather than the lanolin itself. Lanolin, as I'm sure you know, is essentially sheep's grease, the grease that's extracted from sheep's wool. It's a superb emollient, and of course it is an ingredient of Nivea, it's an ingredient of E45, and a number of other products. What is used now is highly purified lanolin, and it's very difficult to demonstrate a reaction to it. It's a great emollient. One or two products contain colloidal oatmeal, which has been used for decades, I think, probably centuries, because of its nice feel on skin. And you probably know the Aveeno range, which patients simply love because it feels lovely to use. Some products contain essential fatty acids. Many products contain vitamins, but Often the vitamin is there as a stabilizer for the product rather than because topical application is a way to absorb vitamins. Depends on the vitamin. Anyway, let me move on. I want to say a quick word about aqueous cream. Only one word really, the top one, avoid. Although aqueous cream has been enormously popular, there are two big problems with it. Number one, it has a very low proportion of lipid, so really not enough to do the job, not enough to put a layer of lipid over the skin surface and reduce transepidermal water loss. Secondly, it contains 1% sodium lauryl sulfate. This is an anionic surfactant. It's the emulsifying agent that's in aqueous cream, and it is very toxic to skin cells. It actually damages them. We know this because for years people have told us, particularly children, that when you apply aqueous cream to their eczema, it stings. More recently, studies have looked at this in some detail, and you may remember the publication of some of these in the past couple of years. We know that application of aqueous cream reduces stratum corneum thickness and increases transepidermal water loss. Obviously just what you don't want in dry skin. Moreover, if it's applied to people with atopic eczema, it increases inflammation and it increases skin shedding. So put all this together, and as I say, this is just what you don't want in dry skin. Rather than improving the epidermal barrier, we have ample evidence now to show that aqueous cream further damages the epidermal barrier. This really is a product that is obsolete and just shouldn't be used anymore. So let's turn to something more positive and look at getting the best out of emollients. And there are a few things we need to know. We need to be able to explain application techniques to patients, help them choose appropriate leave-on emollients, ensure that they are using a soap substitute emollient wash product, more about this in a moment, and find out what the patient prefers. So here we are, application of emollients. Well, my watchwords here are frequently, generously, and quickly. You can't say emollients should be applied twice a day or 4 times a day or 6 times a day. It depends on the skin and where it is and what you're doing. So my rule is whenever the skin starts to feel tight, and certainly after bathing, showering or washing. Why? Because whenever you bathe, shower or wash, you will remove some skin lipids. If you have a long hot soak in a bath, which so many of us enjoy, you'll remove a lot of skin lipid. And you really need to get some emollient on within minutes of coming out of the water. Some textbooks say you apply the emollient to seal in the water, but you don't. You apply the emollient to restore what you've just taken out of the skin. How should you apply them? Well, with swift, light strokes. You really need to choose an emollient, or a patient needs to choose an emollient that works on their skin. And if so, you can apply it with swift, light strokes and it will be absorbed fairly quickly. We want to avoid rubbing as far as possible. As I explained before, rubbing often starts off itching, and itching leads to scratching, and so on. Gentle massage is okay, but something that is so stiff that it needs to be rubbed in is going to do more harm than good. Now, a few words about leave-on emollients. This comment here is because if you look at the NICE guidelines for treatment of eczema in children, you'll see that it is possible in young children sometimes to use one product as leave-on and as a wash product. And that's the only reason that comment is there. Generally, when we're dealing with adults, we find that people need different products for different areas. Every woman will know you wouldn't put the same stuff on your face as you would, say, on your legs or ankles, where the skin's a whole lot drier. And it's the same for patients. They may need more than one emollient, which I guess is great news for sales, But it's also nice to be aware of this because, as I said, the ones that don't work get left on the shelf. So bear in mind, you might need a lighter product for the face and a richer, stickier product for limbs and trunk. People might also need different products for day and night. This is common in the cosmetic industry. We always supply an oil in water product for daytime use and water in oil for nighttime use, because most people will tolerate something a bit richer and stickier at night, but you wouldn't want to go around with that on in the day. And the other thing I want to point out is that people's needs often change with the seasons. In fact, winter can be a ghastly time if you suffer from dry skin. With the onset of autumn and central heating coming on and the weather getting colder and drier outside, well, actually it's not often dry here, but it's colder. This can play havoc with skin and might call for a richer emollient. So just be aware. One emollient might not be enough for one patient for the whole year for all parts of the body. Another important point is that people with eczema can, or dry skin for any other reason, can get through quite a lot of emollient in a week. If you're treating large areas of skin, 500 grams in a week would not be unusual. When it comes to eczema treatment, we know that people who are treating eczema with steroids for flare-up will need 10 times as much emollient as they have steroids by weight. And that's a really easy intervention to make if you spot somebody hasn't been prescribed sufficient emollient. Pump containers for emollients are great because they're very easy to use, and they mean the emollient stays clean. We know that creams, water-based emollients, can support microbial growth, and so it's good if the contents don't get contaminated. There's nothing wrong with a good quality tube. The only thing we're really against is open pots that people dip their fingers into, because not everybody has clean fingers. Pump containers are very convenient to use, of course. But here's something that's really important too. People who have dry skin need to have some small packs, or a small pack of emollient that you can keep in the car or in your desk or in your handbag or whatever, just so that when you need to use it during the day, it's to hand, and you haven't got to carry around a 1 kilogram container or something like that. Now, this is a chart that you might find useful. It's from a paper put together by a multidisciplinary group, and I'll just take you through it briefly and explain how you can use it. This column shows the class of emollients from simple cream, simple emollient ointment, humectant containing emollient, antiseptic and antipruritic. The next column gives a bit of a definition. The middle column gives a few examples. Only a few. You might want to fill in a few more when you look at your stock and see what you're holding. And some comments about usage and who the priority groups are. I think this can be useful, say, if you're helping a patient to choose an emollient, if they're in that position. Because what I would say, if somebody has been told to find an emollient, is don't just send them to the shelf and say, they're all emollients, just choose them. Make sure they get a simple emollient cream and a humectant-containing emollient, so that they can work out for themselves which suits them better. I can promise you, if you compare on one of your own arms or legs a simple emollient cream like, say, Diprobase or E45 with one of these humectant-containing products like Balneum or Eucerin, you will notice the difference. You'll certainly notice the difference hours later because these have much longer lasting effects. Incidentally, I mentioned ceramides, and Balneum is the only one here that also contains ceramides. Balneum, Eucerin and Calmurid all contain urea, and Neutrogena Dermatological contains 50% glycerin. These are all good-going humectant-containing emollients. I also mentioned earlier the use of lauromacrogols. That's what you've got in the antipruritic emollients. And for some people, if someone says, I've got dry skin and it's really itchy, then these products, Balneum Plus Cream or E45 Itch, contain lauromacrogols, One or two others do as well, but these are just examples. And that can be the thing that really changes things for a patient. Itching is so intolerable. If you can help people with itchy, dry skin, you'll be doing people a great favour. Now, I mentioned earlier the importance of soap substitutes. So let me recap. Washing with soap or with harsh detergents, and this includes bubble bath. Bubble bath is a real no-no if you've got dry skin. One of my colleagues, a dermatologist, says if it foams, it'll strip the oils out of your skin. Worth bearing in mind. These things really dry out the skin. They strip out the oils. So, of course, you still want to wash if you've got dry skin, so emollient wash products are essential. Because what's the point of putting on a nice quality emollient if you then wash with soap or a harsh detergent that takes it all away again? There are a number of emollient wash products formulated for use in this situation. Of course, there's still a detergent in there. It's the emulsifying agent, but they're mild detergents, and they're much gentler, and they allow people to wash without seeing the damage done by soap and harsh detergents. There are emollient wash and shower products. There are also shampoos, and often these products are also needed for shaving. I'm talking about men shaving, but of course it could also be for women shaving their legs and so forth. Here's a similar table for emollient wash products. Again, the class down here, emollient wash products and antiseptic emollient wash products, and some definitions, some examples down here. What I should say about these is they look creamy when you put them on. They don't foam up like soap and bubble bath do, but they do emulsify dirt and grime and sweat, and they can be rinsed away with water. And they leave the skin not feeling tight, which is really critical. The final bit of the armamentarium, if you like, is bath emollients, things you add to the bath. And again, we've classified these as simple bath oil, antiseptic containing, antipruritic. These are always used in addition to the other products. They're not enough on their own. Essentially, a simple bath oil will deposit a layer of oil on the surface of the bath water that coats the patient as the patient gets out of the bath. So it's a way of getting some oil back onto the skin. The nice thing about them is that if you have eczema, getting into bath water really stings, and these take the sting out of the water, which is quite a plus, really. You've probably noticed there's antiseptic bath oil here, and on the previous slide, I'll just go back, there was antiseptic emollient wash products. I think on an earlier one, there were antiseptic containing emollients too. I just want to point out, if eczema or dry skin is infected, these are not adequate treatment. This is a kind of adjunct for keeping clear of infection, but these are not adequate treatments for infected eczema. Now I have a few words to say about medicines use reviews for dermatology patients, because I think this is an area where you can do a tremendous service to the patients who have prescribed treatments. And I would argue that dermatology patients are the patients par excellence, if you like, who deserve medicines use reviews, because oftentimes they have multiple treatments, they have few instructions on the label, or it says something like as directed, and often we find they have insufficient information or understanding about the nature of the disease, the purpose of the treatment, the time course of the treatment, what to expect from it and when to expect something from it, and the way in which it should be applied or used. For a time I worked in a psoriasis clinic, and I was astonished at the number of people who would bring their treatments back to the clinic and say, it doesn't work, give me the tablets. And they would have a sack full of ointments and creams, some hardly used at all, because by the time they got home they'd forgotten the instructions and forgotten what was to go where and how to use it and what to expect from it. So I am quite convinced we can help people with dermatological disease tremendously here. I would suggest to you that MUR triggers could be, one would certainly be people who've got apparently appropriate treatment, people who've got what you might call the textbook treatment, but who are not getting the expected effects, or who are getting undesirable side effects, or who find the products intolerable or unpleasant, or simply those who appear to have misunderstood how to use them. And in the workshops in the autumn, I'll go into some examples of the kind of things that come up. Some of them are a little unexpected, or were unexpected to me when I first came across them. But it opened my eyes to how far wrong this kind of treatment can go, just by accident. Finally, here are some examples. These could be triggers for medicines use reviews, I suggest. So if someone has a prescription for a topical steroid and it doesn't include an emollient, we know you need to use them together. You don't give up the emollient when you use the steroid. If you have a patient medication record that indicates unexpectedly low use of emollients, that should be a trigger for medicines use review. Or if a patient mentions that an emollient does not work, well, time for a review to see whether they're using it appropriately or whether they really have got the wrong stuff or they're using the wrong stuff in the wrong area, as it were. Well, last word here, can I remind you that patient support groups offer an enormous amount of very valuable support to patients, and you can perform a great service by signposting patients to these societies. You can find the addresses for these societies on the internet very easily. The National Eczema Society, I strongly recommend to any of you because they provide masses of useful information and will provide it to you too. But signposting a patient to the organisation is great. Sometimes people find at last that they're not alone, and other people have had their problem too, and it can be a tremendous source of support. So a nice thing to do. The product information. Well, that's all I've got for you this evening. I know it's been a bit of a whistle-stop tour of Emollients, and in some ways it's only an introduction. But this will form the groundwork for a more detailed workshop in the autumn. I hope what you've got from this, at least, is to remember that emollients protect and repair the skin barrier. And if you can help patients to find the one that suits them by using some of the logical approach that I've outlined to you, you can help children, adults, and the elderly to look after their skin better. And I know you'll find that a tremendously rewarding experience. Thanks for listening.
Okay, thank you very much, Christine, for your presentation. It was really, really informative. I do have some people who have actually typed in some questions. So what I'm going to do, if you don't mind, I'm going to open up the floor to everybody, and we'll take it from there, if that's okay. So
yes, that's fine.
Yeah, okay. Okay, everybody is off mute now. So I think, Vipin, you wanted to ask something?
Yeah. Hi, Christine. Thanks a lot for a
Hi.
very informative talk. The question that immediately crossed my mind is in my area, the local practice I deal with, the spend to prescribe Cetraben as the first choice. Where does it fit in your chart of the emollients?
Oh, I should have put it in, shouldn't I? As far as I can remember, Cetraben is a simple, it's just a simple emollient.
Right, I thought so, and I think that the shift towards that happened on the basis of a study done by the manufacturer that implied that it's least wasted product.
I do recall, yes, I recall the study. This was to show that if you used their special pump dispenser, you wasted less than you do if you have it in a tube. But I have to tell you, maybe this is tongue-in-cheek, but that's not my number one criterion for choosing an emollient.
No, I agree, and that's the question.
Well, yes, I'll put my neck on the line. I would always recommend a product that contains a humectant. And that's not because this is sponsored by Almirall. That's what I do and have done for years.
Thanks a lot.
Okay. Stephen, was there anything else that you wanted to ask? I think you asked something else. Was it about...
I'm curious about unguent to MUR has any role.
Oh, unguent to MUR. That's a lovely product. Yeah, oh, yes. The thing you find with it feels very nice indeed. It's different from many others, and technically it's again a simple, it's just a simple emollient cream. It contains colloidal silica, and I don't know whether that accounts for the nice feel. I have the impression it's actually quite rich in lipid, and it didn't get used an awful lot because it used to be more expensive than the others. I don't know if it is now. And the other thing about it is if you do a workshop and you pass it round the room, half the room says this is a lovely product, and the other half of the room says this smells like dog poo. And obviously, if you're in the dog poo camp, then you wouldn't use it a lot. Now, I think it's actually lovely. It feels nice, and to me, it smells nice. But perhaps that illustrates for you how personal these things can be.
Indeed, yes.
Is that a help?
Yes, thanks a lot.
I'm a great believer in MUR. I would keep some if I were you.
No, I was just tempted to sort of MUR the odd few patients who are on that product actually, but now you clarified the...
Okay, it's a nice emollient.
Indeed, yes, thanks.
Okay, brilliant. Does anybody else have any other questions that would like to ask at all? Now's time. Silence.
Well,
Okay.
I thought Sam had got her hand up a minute or two.
No, it was I accidentally muted her by accident. Unmuted her, which I shouldn't have. So,
I see.
there was a couple of questions I wanted to ask, if that was all right. Just to get the ball moving, really. I mean, obviously, I asked earlier on about, just for those of you who weren't here, I asked earlier on today with regard to the overall economic issues with regards to dermatology and how much it costs. But the thing is that one thing throughout the day actually did sort of cross my mind, and I thought you'd be the ideal person to ask, would be, obviously with PCTs at the moment, one of the things that they are doing is cost cutting in effect. You know, it's happening with, the inhalers, it's happening with statins, it's happening with all the quick ejectors, etc.
Yeah.
And from your experience, I mean, what exactly do you know generally what they are doing with dermatology products in general from your experience?
No, is the short answer. The longer answer is that periodically what I see is PCTs that have clamped down on the use of anything other than the cheapest emollients, and sometimes other products as well. And I would say two things. Firstly, we know that dermatological complaints account for a very large proportion of GPs' workload, far greater than I think has ever been admitted in the past. A survey done by, well, not the survey, the analysis done by Nottingham University a couple of years back showed that 24% of patients consulted their GPs for dermatological complaints in a one-year period.
About 1 in 4 or so, yeah.
Yeah, and that's an extraordinary number. That means that dermatological issues account for a lot of GPs' time. And we also know, if you start looking in detail at the report, what the breakdown of those is. And there's a lot of eczema in there. Now, one of the things I would argue is if you don't provide people with treatments that work, you have the archetypal revolving door patient. You give them an ineffective treatment, they're back sooner than they would be otherwise. From a patient organisation perspective, I have to say, I'm in favour of giving people effective treatment and teaching them how to manage their condition, because that's what we need to do with all long-term conditions. I've gone into rant mode now, but...
Well, that's what I wanted, really. I think we're both thinking the same way here, really.
Yeah.
I think most of the people here will be thinking the same way as well, from their experience with these formulas as well. And maybe that was hence the question, really, was designed for that sort of response, I suppose. I suppose it was a loaded question in a way.
Well, no problem. I think it can only be a false economy. After all, in the grand scheme of things, emollients actually don't cost very much.
Right. Right. Okay.
In my opinion.
Okay. Does anybody else have any comments about that at all? Okay. Just another question then. So you answered that one. That's really helpful. One other thing that crossed my mind is obviously with PCTs dissolving and with clinical commissioning groups coming on board as well. Is there any? I mean, I know that there's not going to be a set formula of how to go about doing this, but is there any way in which the local community pharmacist can help influence that policy of specific products being not necessarily promoted, but being on the formulary for specific conditions? Is there any way in which, how would you best suggest that the local pharmacists themselves can sort of like support that?
This is a difficult one, but I guess it's, and this is something, let me first say, I'd be very interested to work with you on.
Right.
Because I can see this is important. I can only say, I think if you can present a good case, that's to say, have an organised approach to it, and suggest that you could actually take on the management of some of these patients with long-term conditions, if you had a protocol in which to work, that everybody could sign up to. And after all, we have an increasing amount of information now. We have the nice guidelines for eczema treatment and the fine guidelines for psoriasis and so forth. There's an increasing amount of information out there so that you could build your protocols on.
Right.
I think that's about the best I can do. No,
I wasn't expecting anything too much. It's the same sort of problem that's experiencing with not just dermatology, but with all the other areas that are out there as well. And obviously with the community pharmacists out there, they're technically in the middle of it all as well. So it's just a thought as to, I mean, obviously you've got the medicines management teams at the moment. They tend not to work too closely. In actual fact, I mean, some of them are downright hostile to the local community pharmacists as well. And it was just, obviously this could be an opportunity in a way whereby we can influence the policy. Yeah. And it was just a thought as to how that could possibly go about. And you know, if the invitation is there, I mean, I'm sure that we would be almost more than happy to work with you on that one to try and stem the flow in effect to some of the most cheaper and probably more useless products as well out there. So you could certainly help with that one as well. Yeah. Any comments from anybody on that one at all? Silence. And okay, one last question then from me, and then okay. One of the things that we discussed at a conference a couple of weeks ago was the opportunity to go on to independent prescribing and so forth as well. And one of the things that also popped into mind just now as well was the pharmacist of specialist interest. And dermatology does seem like quite an attractive topic, specifically because of the fact that it is so vast anyway, and also because there's a lot of things that a pharmacist can actually do on that. I mean, what are your thoughts on that? I mean, I know it's quite a hefty path to go down.
No, I'd like to tell you, I've got thoughts on this one. Several things. Firstly, dermatology, along with anticoagulants, is one of the only two I know where we actually have an established Department of Health approved guideline for what you need to be able to do to be a pharmacist with special interest.
Okay.
And a lot of and I can point you to the documents so that you can share them with the people who've taken part in this.
That'd be really useful, thank you. Yeah.
Because it's a very nice package of documents, and a lot of the skill set is the same as we would expect for a GP, but it's all set out. This is a tremendous piece of work done by Beth Taylor at the Pharmaceutical Society, working together with the British Association of Dermatologists and the Department of Health. So, number one, we've got the documentation to support all that. Number two, yes, there's lots of things in dermatology. There's thousands of diagnoses, but in fact, what makes up the vast majority of what is seen in primary care is eczema, psoriasis, and acne, and the identification of skin cancers, obviously. Now, I'm not talking about what comes into the pharmacy, because loads of other stuff, all the warts and athlete's foot and so forth, comes into pharmacies as well.
Mm.
But in fact, you don't need to know about all 4,000 diagnoses, because the big things that are taking up the time actually boil down to a relatively discrete group.
Okay.
So, all of this makes it a very good area for development. And of course, the other thing is that we're talking about chronic conditions, which is absolutely where I think pharmacist prescribers, many of them, wish to be and have the skills to take care of patients. And finally, what I would say is, I'll give you the floor back in just a moment. I have a list that I compiled with a colleague of places that offer courses for pharmacists who wish to qualify as pharmacists with a special interest in dermatology.
Right, okay.
Which I can also provide you with.
That would be really, really helpful. Thank you, yes.
I think it's a great area for pharmacists to be in. I think not to compete with GPs, but to help patients to manage for themselves.
Yeah, we certainly, I mean, it certainly raised a lot of, especially when we, sorry, there's a motorbike we just passed behind me, so I don't know if you heard that. It certainly did, the independent prescribing especially did raise quite a lot of interest, and we've got a lot of, we're already well on the way to developing a service whereby we can match effectively, get not in the in the real sense of the word, but try and get GPs and pharmacists to date each other in a sense, so that they can have their mentorship. So we've got more or less that bit sorted out, and we're working currently with the university to try and get the course sorted out as well. So we should have an infrastructure in place.
It's the University of Hertfordshire.
It is, yes.
Yeah, because they're one of the places that offers the course.
Exactly, and that's what hit me as well, because that's what they mentioned as well.
Yeah.
And I thought that the two just tie in really, really well with each other as well. So it's something that we're working on at the moment to try and encourage this, and especially, I mean, it just so happened to be by fluke that it happened to be the Hertfordshire University, but it's something that I'm sure we can work on as well. Just one last question, just from me, and then I'll sort of finish off here. For the mere mortals amongst us, I mean, obviously, pharmacists with specialist interests isn't going to be something that everybody's going to want to go down towards as well. But is there any opinion that you've got with potential PGDs as well for conditions in eczema and psoriasis, especially, for example, the steroid-based ones and so forth? In the specific conditions, or is that something that we shouldn't really be looking at?
I'll be honest, I haven't thought about this at all.
Right.
So I don't know. What I do know is that we have in this country one thing that, as far as I know, is unique, in that we can actually sell a moderate potency topical steroid for the treatment of eczema over the counter. I don't believe any other country in Europe can do that.
Right.
So we've already moved somewhat, and I'm all in favour of P items. I think they increase patients' access to medicines. And even if you don't want to go down the route of being a prescriber, you can actually go quite a long way in upskilling yourself so that you can help to guide patients in their treatment in this area.
Okay.
I think that's as much as I would say. I don't have an opinion on PGDs. I haven't thought about it.
Well, another of I until just now, literally 2 minutes ago. Right. So it's just something which crossed my mind again. Okay, Christina, thank you very much. I'm just going to open up the floor one last time to anybody else who wants to ask. We're sort of like running quite late now, so does anybody else want to ask anything before we switch off? Okay, I'll take that as a no then, yeah. Christine, thank you very much for your time today, and I think everybody here is really thankful for the information and the guidance that you've provided to us. What I might do, if this is all right with you, is to perhaps email you with a request for the documents that you suggested, especially with the... If that's all right with you.
No, please send me a reminder, and I'll do that with pleasure.
And I'll forward it on to all the people on this webinar as well. So Anyway, I hope you lot have all found it very useful as well. As said earlier on, we're going to be supplementing this with a number of workshops later on in the year. So please do keep an eye out on it. And as usual, this is going to be on the website. So if there's something that you have missed out, or for example, especially with a table, for example, I mean, I wouldn't expect you to memorize that on the one. That's going to be on there as well, so you can take your time and look through that as well. Okay then, thank you very much, Christine, and thank you very much for everybody else.
Thank you for having me.
No problem, thank you. And we'll see you soon, I hope. Take care, yeah?
Okay, bye.
Take care, bye-bye. Bye-bye now.